Hello, everyone, and welcome to the 18th meeting of the Standing Committee.
Ceded territory of the Algonquin Anishinaabe Nation. Aujourd'hui, on continue notre troisième.
Today, we continue our third study on the administration and accessibility of the Non-Insured Health Benefits Program.
We'll be hearing from the Honorable Patty Hajdu, Minister of Indigenous Services, and officials from the Department of Indigenous Services and the Department of Crown Indigenous Relations and Northern Affairs. Je voudrais vous rappeler des exigences du Bureau de...
I would like to remind you of the Board of Internal Economy's requirements regarding physical distance and masks.
I would like to outline a few rules to follow. Members or witnesses may speak in the official language of their choice. Interpretation services in English, French, and Inuktitut are available for the first part of today's meeting. Please be patient with the interpretation. There may be a delay, especially since the Inuktitut has to be translated into English first before it can be translated into French and vice versa. The interpretation button is found at the bottom of your screen in either English or French or Inuktitut. If interpretation is lost, please inform me immediately and we'll ensure that interpretation is properly restored. The raise hand feature at the bottom of the screen can be used at any time if you wish to speak or alert the chair. Before speaking, please wait until I recognize you by name. If you are on the video conference, please click on the microphone icon to unmute yourself. For those in the room, your microphone will be controlled as normal by the Proceedings and Verification Officer. When speaking, please speak slowly and clearly. And when you're not speaking, please put your mic on mute. And a reminder that all comments should be addressed through the chair. Colleagues, you all know the standard procedures for these meetings, and we are about to hear from Minister Hajdu. Minister Hajdu has requested to speak for 8 minutes. As you know, our routine motions normally limited to 5 minutes. I understand Ms. Gill and Ms. Idlaut are fine with 8 minutes. I'd like to ask the Conservatives whether they're okay with 8 minutes.
Mr. Vidal indicated that the Conservatives are fine with that, sir.
Very good. Thank you very much. With that, I'll turn the microphone over to Minister Hajdu. You have the floor for 8 minutes.
Well, thank you very much, Mr. Chair, and thank you to my colleagues for giving me a little bit of time. Kwekwe, Tansi, Anusakut, good morning, bonjour. I, too, am on the traditional and unceded territory of the Algonquin Anishinaabe people today, but from the traditional Robinson Superior Treaty area, and I'm very happy to be here. I think, first of all, in this conversation, it's our duty for all of us to acknowledge that colonization through displacement, discrimination, and systemic racism has caused immense intergenerational trauma for Indigenous peoples, and it's perpetuated inequities in the determinants of health and well-being. In line with Canada's commitment under the UN Declaration on the Rights of Indigenous People and the Truth and Reconciliation's calls to action, addressing health inequities is a key priority for Indigenous Services Canada. To reconcile means that we must move forward on, importantly, equality, truth, self-determination, and on services that are designed by and for Indigenous peoples with sufficient funding and supports in place for people to access them. We need to do better because healthcare is a right for all Canadians. We recognize the strength of Indigenous peoples, families, youth, and communities who have been pushing governments to find a holistic, distinctions-based approach that will improve access and culturally relevant, trauma-informed, and community-based services. And we know that there is still much work to do together. The federal government cannot act alone in implementing all the changes necessary. Through conversations with Indigenous partners and the provinces and territories, however, we can chart a path forward to better serve Indigenous, Inuit, and Métis communities across the country. The Non-Insured Health Benefits Program administered by Indigenous Services Canada is one area where considerable work has been done to address these inequities. And the program provides First Nations and Inuit with health benefits that are not covered by provinces and territories, including things like prescriptions and over-the-counter drugs, dental and vision care, medical supports and equipment, mental health counseling, and transportation to access health care services that are not available locally, regardless of where clients live in Canada. These benefits are different than other private or public health insurance programs because they're not income tested and there are no co-payments or deductibles. The NIHB pharmacy benefit is one of the largest publicly funded drug plans in the country, and it's guided by 3 expert advisory committees of highly qualified health professionals who provide impartial and practical expert medical advice. In partnership with the Assembly of First Nations, we're working to review the NIHB program. It provided partners an opportunity to identify and address gaps in benefits and streamline service delivery to be more responsive to client needs. And this collaborative work has resulted in tangible changes, such as additional supports for expectant mothers so that they don't have to travel alone if they need to travel outside of their communities to deliver their babies. The NIHB program also engages regularly with the Inuit Tepirit Kanatami to discuss Inuit-specific issues. With the signing of the 2017 Canada Métis Nation Accord, we have begun to transfer funding for distinctions-based Métis-specific programming to Métis governments. Now, as someone who's worked on the issue of mental health and substance use for over 2 decades, and someone who regularly hears stories from communities each time that I'm on tour, I'm also acutely aware that there is no one single approach or program that will address the varied, complex, and interconnected drivers of mental wellness. The department works closely with First Nations, Inuit, and Métis partners to improve service delivery, which means supporting increased access to quality, culturally grounded wraparound care, such as Anishinaabe Aski Nation's Choose Life program. It means making sure that federally funded programs provide flexible supports to organizations that support people to stay connected to their culture, traditional healing, and traditional ways of being. For example, under our government, for the first time, coverage is provided for traditional healer services in support of mental wellness. And we've made significant recent investments to improve mental wellness in Indigenous communities to a total of about $645 million in 2021. Budget 2022 proposes to commit an additional $227.6 million over 2 years for trauma-informed, culturally appropriate, Indigenous-led services to improve mental wellness. Now, these investments include a renewal of essential services such as crisis lines and mental health, cultural, and emotional support to former Indian residential schools and federal day school students and their families, as well as those affected by the issues of missing and murdered Indigenous women and girls. Medical transportation is also essential for rural and isolated communities, and while provinces and territories manage the delivery of physician and hospital care, we know that this is not always possible. In 2020 and 2021, NIHB invested $525.7 million in medical transportation. This is about 35.3% of the total NIHB expenditures. This, along with other prenatal supports, ensure that families get the support where they need it. The NIHB dental program is also universal. It means it covers all eligible First Nations and Inuit individuals regardless of age, income, or other measures of socioeconomic need. Again, recipients don't need to pay deductibles or co-payments and have no annual maximum. In 2016, NIHB established an external advisory committee to support the improvement of oral health outcomes, and we are committed to working with other partners to take best practices as we look to explore dental coverage for all Canadians. Mental wellness, medical transportation, and dental are just 3 examples of the comprehensive supports provided through NIHB. There is much more work to do, and I'm committed to work together with Indigenous leaders and communities to improve services. I'm very pleased that I have Valerie Gideon, the Associate Deputy Minister, and Scott Doige, Director General, Non-Insured Health Benefits, in the room with me, as well as Dr. Evan Adams, Deputy Chief Medical Officer of Public Health, who you heard from earlier this week, as well as Keith Kahn, Assistant Deputy Minister, First Nations and Inuit Health Branch, are on video, and they will help me in responding to your questions. Miigwech, Nakumek, Masi, thank you, merci.
Thank you very much, Minister. We'll now proceed with the first round of questions, beginning with Mr. Vidal. Mr. Vidal, you have 6 minutes.
Thank you, Mr. Chair, and thank you, Minister, for being here with us again today and talking about some of these very important issues. Minister, as you talked about in your comments, and as I think you're fully aware of kind of my riding, you were out in Saskatchewan here a few weeks ago, but people travel, great distances to access medical services, to attend appointments, and you talked about medical travel in your comments. There's a lot of people that rely on that in my riding in very significant ways because of the great distances. They're often hours and hours away from these appointments. And one of the things I've run into in the last few weeks is on multiple occasions I've heard from people that operate the medical taxi companies how they're struggling with the increased costs. I mean, obviously fuel prices, and that gets exaggerated obviously in a remote location and distances. And I see my colleague from the block nodding as we shared some common questions today in question period about remoteness. But these are a lifeline for many of these people. And if the medical taxi companies can't survive the increasing costs, that creates a whole new issue for us, right? So we heard from the vice chief of the FSIN the other day about the ongoing reviews. We referenced them today as well. I'm just curious in that process if there's anything going on in the context of this medical taxi service. I mean, is there some review that creates a fee that adjusts with fuel prices or anything that would help these places survive, these businesses survive?
Well, thank you very much, MP Vidal, and I'll just generally say that inflation is top of mind right now for Indigenous Services Canada, not just in this aspect of medical care, but certainly in the aspect of infrastructure development and many other aspects that the department supports. So maybe I can turn to Val or Scott to answer specifically the question.
I'll start, and then I'll invite Scott to add briefly. So we have, to reimburse mileage rates, we use the National Joint Council Commuting Assistance, which actually does take into account cost drivers such as inflation. We are in the process now of doing a review of the medical transportation benefit with the Assembly of First Nations. We made a change last year, for example, of increasing by 25% meal and accommodation rates in response to calls for the fact that we hadn't sufficiently increased our rates for a number of years. So I'll just invite Scott to speak to anything that's more specific to the medical taxi issue.
And I'm just gonna, if you can be brief, that's great. I've got such limited time and I have lots of questions. So.
I would have nothing to add then.
Okay, that was brief. Thank you. Minister, another thing you talked a lot about, and I think you're well aware of the problems in my writing is the idea of mental health, the challenge of mental health. I mean, when I was first elected in 2019, one of the first things I dealt with was a crisis at one of the First Nations, very close to my community. And one of the things that I hear on the ground when I talk to the leaders in my communities is that they're looking for something kind of in a, if I could phrase it as kind of a whole family approach rather than an individual approach. I wonder if you could, and again, just because my time is so limited, if you could briefly just, is that going on through the non-insured health benefits? Is there some openness to some new ideas? Kind of where are we at with that?
Yeah, again, thank you for using that example, actually, because there are communities in my riding that are exactly doing that kind of innovation, recognizing that substance use and mental health issues are actually a systemic kind of a community problem, not so much an individual problem. Certainly fits well with an Indigenous lens as well, that a holistic lens of community wellness. And so, yes, there is flexibility for programs that can be delivered that are designed by Indigenous people. I referenced Choose Life in my remarks. This is a youth suicide prevention program that was designed by and delivered by community. And even within the flexibility of that design, individual communities can adapt it to how they need. So, yes, there is that flexibility in the funding to communities to provide family, social group, all kinds of alternative approaches.
Thank you. And Mr. Chair, I'm sorry, I didn't start my clock today, so you're going to cut me off at some point. I don't know where I'm at in my questions today. Sorry.
You have a minute and a half.
Thank you. I'll be very quick with my next question. Minister, you actually referred to this a little bit already, but I want to more directly ask maybe, so if there was an organization that had some kind of innovative, culturally sensitive ideas, and they wanted to do a pilot project, they wanted to get some support for some of those ideas that not only just a community-based thing, a family-based thing, but also in a lot of our areas, we have to do them regionally as well because we can't be everywhere, right? So if there's ideas like that they want to bring forward, what would that process be? How hard is that to actually kind of get the department to do some out-of-the-box thinking on some things they've never done before, maybe is the way I would say that.
I'll answer generally and turn to Val, but it depends on where that community group is. So, for example, if it's in an urban setting, it can be a bit more challenging. But if it's on a First Nations community or in a community, a regional community, tribal council, for example, I think there's quite a bit of flexibility by the department to be able to work quickly on a conceptual idea and then take it from that conceptual idea to actually be able to implement it on the ground. Val, do you want to add?
I would just say exactly that. And wherever possible, we're finding horizontal ways to work across sectors so that we can be more flexible in our policy authorities and our funding envelopes.
Thank you very much, Mr. Vidal. We'll now go to Ms. Atwin. Ms. Atwin, you have 6 minutes.
Thank you, Mr. Chair, and thank you to the Minister for being with us today. I'm speaking from unceded Wolastoqiyik territory here in Oromocto, New Brunswick. And Minister, I just want to thank you again for your remarks and your willingness to address that things have not been perfect up to this point, but your commitment to really righting some of the wrongs, and it's very refreshing to hear that humility. And you and I both share a passion to talk about mental health and mental wellness, and it is Mental Health Week here in Canada. And so I'll pick up on where Mr. Vidal actually asked a couple of great questions around that as well. And I'm just wondering, you mentioned the traditional counselors in particular, and it makes me think about when the community of Attawapiskat in particular, they lost many youth simultaneously, and one of the things that they were really asking for was culturally appropriate mental health supports and to have Indigenous-led programming. So could you talk a little bit more just about how our government's investing in mental health specifically and around cultural healers and how that's been expanded in the last little bit? Thanks so much.
I'll try not to eat up most of your time because you're right, this is an area I'm passionate about. And I think that flexibility in the way that Indigenous people, but even non-Indigenous people, are able to access mental health and substance use supports is critical to really moving forward on this very difficult issue. For far too long, governments, including ours, have tried to overlay a very Western approach to wellness or healing, in particular around substances. And it is a very individualistic approach. If you think about, one-on-one counseling, if you think about even 12-step programs, which I know are undoubtedly very helpful for some people, it doesn't have a cultural lens or a cultural perspective that can necessarily easily translate in some communities. And so as Deputy ADM, Deputy Minister, as Val said, we know her as Val, that's how accessible she is. As Val said, the working with communities on that innovative approach that will work in their communities is really what I think is going to be a game changer, because the many communities that I work with in my own riding will tell me that substance use and mental health is a systematic problem. And you can think about this from the people in your life that you've loved to have suffered. You can send someone away for treatment, but if they come back to exactly the same system, it's very hard for them to stay recovered. But some communities like Long Lake 58 in my riding are doing entire friend group treatment and doing, group kinds of approaches that help that person and those people lean on each other in their journey of recovery.
Oh, thank you so much. In the spirit of talking about some of the other improvements, so it's clearly an improvement that's been made to the NIHB system. What are some of the other areas that has been looked at by the department to really make sure it's more user friendly, perhaps, or that accessibility piece? Because we've had some pretty powerful testimony in our committee so far around this, and some of the areas that may still need a focus for improvement. But what's been done so far to kind of increase the accessibility of this program?
Maybe I can turn to you, Val, in a moment, but I think the top line I would say is that the department is really leaning into self-determination, into autonomy, into equity, and of course into honesty. And I think using those principles to guide the redesign of programs has really helped to shift the trajectory of the department overall. So maybe Scott or Val, you can talk about what that looks like in practice.
I can start. So I'll give you lots of examples, but, just the fact that now every pregnant woman that needs to birth outside community has access to an escort, where the criteria is no longer limited to a medical need. In dental, we've significantly increased coverage for preventative services, like, for example, even adults having coverage for fluoride treatments, right, which before used to be limited more to children. We've removed a number of pre-approval requirements for a number of our both pharmaceutical pharmaceutical and medical supplies and equipment categories. And, we have information that's publicly available around all the improvements that we've made through the joint review process that we had with the Assembly of First Nations. And I believe you're going to hear from one of our core committee members that's been part of that process as part of the First Nations Health and Social Services Commission of Quebec and Labrador. Gender affirmation treatments and products and support for that, removing pre-approval requirements for a number of those. These are just examples, but I would just say that having First Nations representatives and Inuit representatives provide us with that feedback very directly has helped us tremendously to improve access, and we're continuing down that path.
And if I could just follow up on that, what does that look like, that process of, where you're getting that feedback from community members or from users of the program? What are the mechanisms for communicating perhaps a complaint or a suggestion?
Well, we started out with a Chiefs Assembly resolution, which is pretty powerful, and then a Minister of Health commitment to actually undertake the review process. We went benefit by benefit. We funded the Assembly of First Nations to coordinate the process. They identified regional representatives and NIHB navigators. We have over 30 NIHB navigators that are First Nations or Inuit employed that are working directly with clients and then coming back and giving us that feedback. So those are just examples of how we have a very active network of First Nations and Inuit client representatives really coming to us for those service improvements.
So thank you very much, Ms. Atwin. There's only about 10 seconds left there. On va aller à Madame Gill. Madame Gill, vous avez le micro pour...
Mrs. Gill, you have 6 minutes. Thank you. I would like to thank Mrs. Hadju and all the witnesses for being here today. Madam Minister, since 2013, there's been this NIHB. We've looked at billing, dental services, and since centralization, there have been a lot of problems, and that this has increased the administrative burden, and people have asked for more flexibility. Even when we're told that the Assembly of First Nations for Quebec and Labrador tell us that when there was a Quebec office, this made things a lot easier. It made the communication easier and allowed for better communication. It was more efficient. And even today, what we see is that we have increased difficulty when we talk about reimbursement for services, payments. This is an essential service. Same thing for healthcare professionals. These are examples that are mentioned, and sometimes they decide not to serve the population because, well, when you're not paid, it's difficult, so they just give up. I would like to know what is being done right now in order to make sure, well, I don't know if there's any thought process underway to decentralize this system or to see how you can work in order to ensure access. We're talking here about access to services for Indigenous peoples.
Well, maybe I can just highlight a couple points and then turn to Valor Scott. But I will say that the NIHB program encourages dentists to enroll directly with NIHB so that clients don't have to be billed. They don't face charges at the point of service. And that would be, I guess, a form of decentralization in that no matter where a dentist lives, they can work directly with NIHB and clients can have that direct access. And also, we provide coverage of travel costs to access dental services when not provided in the community or a resident. So again, trying to make sure that no matter where a person lives, that they are fully able to access care regardless of their location. But maybe you can talk a little bit about the decentralization in general.
Okay, sure. So with respect to service providers, we watch our provider enrollment numbers very carefully to make sure we're not losing providers. For example, with dentists over the last 5 years, we've actually had a 12% increase in the number of dentists who are actively providing services. So these aren't just dental offices that register just in case they see an Indigenous patient. These are active service providers. With respect to some of the concerns you...
If I interrupt you, I have another question. You're saying that there's an increase, but at the same time, there's still this issue between isolated regions where you can have an increase, but I know that there's not an increase of dentists in isolated areas. Maybe what you're indicating here is in an urban area. The figures can be okay for some regions, but in other regions, this has zero impact. Sometimes there might be only one dentist, not even per community. There's no dentist in these communities, all of them. Sometimes you have to drive kilometers. Sorry, but...
So when it comes to those types of situations, and thank you for clarifying, we do do our best to provide contract dental services, whether through contract dentists, hygienists, in order to try to get the services in the community. That is the number one priority, and a lot of our expenditures in dental are really geared towards that. We're always open to trying to devise ways to improve how we can deliver those types of services, because, the fee-for-service business model where people have to leave their community is really not optimal. So certainly we're open to any and all feedback to try to improve that service.
Et pour la question de la décentralisation.
And as for decentralization, well, I'm not saying that it would be over the short term, but if you say, okay, things are not working, and the PMQL is saying that it's not working, and that they would like to find a new model, come back to a former model perhaps, or to optimize something new, is there any openness to this? It's a request that's coming from the Indigenous communities themselves.
Yeah, go ahead.
Just going to say, on travaille depuis.
For several years now, we've been working with the Commission on a governance project so that First Nations are able to take control of all of these programs for health and social services. But on a national level, the centralization of dental services has allowed us to meet the standards throughout the country in a way where beforehand there were regional offices, there were payments that were 12 weeks late. And so this is the only way that we were able to manage the issue of capacity through our regional offices, was truly to centralize administrative services, to be able to better support dentists that are registered for the program. And there are 15,000. Did you do an assessment to see if there were more problems in some communities? So you might be helping someone, but hurting someone else. Well, the last assessment when it was in 2015, and we are starting a new assessment process right now, and this will last up until it will go to 2017, 2018, and we will ask that specific question.
I think Val touched on it briefly, but as you know, in my mandate letter, I am mandated to create co-developed health legislation with Indigenous communities and/or regions, and that is a form of decentralization that's working extremely well. If you look in BC at the First Nations Health Authority, increasingly self-government is proving to be a way of decentralization that is meeting Indigenous people's needs. So that's an exciting piece of work coming.
Merci, Madame Gill.
Thank you, Mrs. Gill. Mrs. Idla.
Thank you. I welcome you to this. I've enjoyed the presentation. It's informative.
The interpreter, sorry, but I don't hear the English translation in the booth.
Sorry, Mr. Chair, we're not getting the interpretation, so I can.
Interpreter.
Okay, there. Thank you. I welcome you to this very informative presentation. I have a question about traditional healers. They are life counselors, Lifeline, most often. How do you recognize and validate the important work that they do in the community? But if you could let us know how you can further assist traditional healers to do their work, would you let me know now?
Able to compensate traditional healers for their work, but I will turn to Val to talk about how traditional healers are selected and how they're recognized.
So in 2017, through the Non-Insured Health Benefits Program, we were able to access funding for the first time to actually support First Nations and Inuit to include traditional healing services. But they manage those services. So they identify the traditional healers, they compensate them, they support the services. The government does not do that directly. So, for example, IRC, Inuvialuit Regional Corporation, is funded to provide those services. We also offer services through the Indian Residential School Health Support Program. And again, there are many Northern residents who access that program. For traditional healing services, we do not, again, sort of recognize them or certify them or anything. We just receive a letter usually or a note from the community organization, the Inuit or the First Nations organization that advises that this traditional healer or this cultural practitioner is recognized or is part of their services.
Secondly, I would like that in writing of what is available and who are those resources and counselors that are listed as your traditional counselors. Yeah, you say the Inuvialuit have a list of traditional counselors. That would be very helpful to have the list. Thank you. Secondly, I wanted to ask you about people who travel, who go on medical travel. What are the agreements when it comes to medical travel? I have heard of an elder by the name of Raymond Ninguchak. Many people know him, Nunavut, as he was at the Embassy West in Ottawa suffering from dementia because the doctors had said that they could not bring him back home because they had no specialized caregivers for his condition. The family petitioned to have him brought home for his last days. They identified caregivers within the family who would look after him with a schedule. They provided all that, but they kept refusing the family. So the family members fundraised up to over $20,000 to have a charter bring him back home for his final days. He went home. Now we know he's happy. He's got good caregivers in the family. It shows to us, to the medical people, that an elder who's unhappy, removed from his homeland into a foreign land, can survive in their own home environment. How can we make it understood that we too are capable of looking after our own elderly and sick if they are homesick for their homeland in their final days?
A touching story, and it's one that I've heard all across the country from Indigenous people, as many Indigenous communities are trying to adjust to increasingly more local elder care, whether it's creation of long-term care homes, which many communities are working on, or more supports for active at-home aging, which many people would prefer than long-term care homes. We have to do better by elders across the country. I would agree with you, and I think that you're raising a really important point. Maybe, Scott, you can speak about this specific kind of topic, but from my perspective as minister, you're right, and the evidence has shown over decades that the closer someone is to family and home as they age, the happier and more content they are, and the better their quality of life is. And that actually matters. So I think that we can do more in this space, and I'll look forward to working with you on that. But I would also like to just turn to Val or Scott if they have anything to say about this specific situation.
Very quickly, please.
I will just say that, the government of Nunavut makes the direct decisions around the coverage, but we pay the costs of those. And I think we do have a partnership table with them, so we can talk about this situation with them in collaboration. But on long-term care, we do have a mandate since 2019 to work with First Nations and Inuit to develop together options for a better continuum of care services, including long-term care, but not just the level for specialized services, but more of this community approach.
Thank you very much. We have time to start a second round at this point, so we'll go to Mr. Schmale. Mr. Schmale, you have 5 minutes.
Thank you very much, Chair, and good afternoon, witnesses. I do apologize for not being there in person, but do appreciate your testimony and contribution here nonetheless. Minister, during our last meeting, we heard from 3 witnesses when we were conducting our study. One was a Plains Cree family physician, one was the president-elect of the Canadian Medical Association, and the other was the vice president of the Indigenous Physicians Association of Canada. Each one of those individuals talked about the crippling bureaucracy that is slowing the care of individuals in their community. Were you aware of this situation? Have you heard this before?
Well, thank you, Mr. Schmale. Not having heard their testimony, it's a bit general for me to be able to comment on that, although I will say that I think the department is working right now to eliminate the layers of bureaucracy and move more quickly to self-determined models of care that will, I think, go a long way in reducing some of the bureaucratic hurdles.
In some of the testimony we heard physicians actually trying to beg whoever was on the phone from the program to approve certain levels of treatment that would most likely have been easily passed through any other existing system, such as a provincial system or what have you. There was even one story that Dr. Makokis talked about where he had to threaten the department itself with bad media coverage in order to get the treatment his patient needed and deserved. Can you also tell us some concrete steps you're doing to maybe improve training, or even on how the department is speeding this up?
Turn to Val to talk about the training, but I will say that streamlining the process of payments for providers, for express scripts, and access to benefits like dental care and vision care is a top priority for the department. But Val, maybe you can talk about, from a practical perspective, what that means with individual employees.
Yeah, so we did implement a mandatory culturally competent training policy in 2020 for all employees in the department. A couple of years ago, within the First Nations Inuit Health Branch, where NIHB is housed, we also implemented an Aboriginal Peoples Employment Program, as it was called at the time, where we asked all areas of the branch to identify positions that would be targeted specifically for Indigenous employees on the basis of the need for cultural competency in those particular jobs, or also if they were offering direct service or partnering or liaising with First Nations and Métis communities or clients. So we implemented a number of improvements. On the NIHB side, we also have removed a number of prior approvals on pharmaceuticals or medical supplies and equipment that relate to the health conditions that were raised specifically by Dr. Makokis. So for example, with respect to HIV treatments, these are considered open benefits. And we now have no need for predetermination for a number of pharmaceuticals or products relating to gender-affirming supports.
You know how many individuals, either total or percentage, that are Indigenous working within this program, or at least taking the calls from Indigenous physicians or healthcare providers?
Do you know, Scott?
I don't have the exact number, but it's something that we could provide. I would also note of the composition of the committees, the expert committees that the minister referenced in her speech. Many of those members are practicing Indigenous physicians, dentists, and folks who would provide us with advice around medical supplies and equipment. And we can get you those figures.
Yeah, I'm just curious because even I think I can't remember which witness it was, but one of them did speak about the fact that there were little to no Indigenous employees working to take the calls that would understand and wouldn't ask questions like, well, can't you walk, instead of asking for transportation. It was just situations like that that were brought up that were quite troubling. Minister, recently the First Nations Financial Management Board, which I know you know about, a top-notch organization supporting economic development for Indigenous communities, it wrote a letter to the standing committee that we're addressing here today. In that letter, the executive chair summed up the situation using the example of housing. And Mr. Harold Kalloch said, as he quotes, while the budget makes significant investments in new housing, it does nothing to change the failed systems for getting homes built, nor does it change the pay-as-you-go systems that support Indigenous housing. So, Minister, are you tackling the systemic inequalities that keep these Indigenous people in poverty, poor health, and without adequate housing? Because clearly, I think although the money is nice, I think what most people are looking for is outcomes.
Well, thank you, Mr. Schmale. And I will say, yes, absolutely. I can, first of all, I also respect the work of the board tremendously and very practical recommendations. We'll be working with a number of partners to streamline how we get the significant investment in housing out the door as quickly as possible. It is my goal to spend every dollar as quickly as possible, obviously through First Nations leadership, to build those homes. This is the top priority for many First Nations leaders across the country, and you're absolutely right. It's a critical social determinant of health. In fact, so much so that it is deeply connected to outbreaks of COVID, to outbreaks of tuberculosis, and of course, many, many other health outcomes. So it's a priority for me. The department and I have had many conversations already on how we can streamline the process of getting money through the door, and I'm working with my ministerial colleagues on that as we speak.
Thank you, Mr. Schmale. We'll go to Mr. McLeod for 5 minutes.
Thank you, Mr. Chair, and I want to say thank you to the Minister and her team for taking the time to talk to us today about this very interesting and very, very important issue in NIHB. One of the main concerns about NIHB that I hear from my constituents and I hear from Indigenous governments in Northwest Territories is around escorts for medical travel. It seems it's very inconsistent. There's some people that qualify, some don't. Some jurisdictions are allowed for more medical escorts than others. It seems like it's not very clear. And this point was echoed by Minister Green from GNBT on her presentation to committee at the last meeting. So my first question is the government of Canada able to make the changes needed to make the process for getting an escort for medical travel easier and also clearer?
Well, thank you very much. And I will just say we work in partnership, as you know, with provinces and territories to augment the cost of medical transport, including Northwest Territories. And absolutely, we have been working on ensuring that people do have escorts, as I think we've talked about, for example, adding the ability for a pregnant mother to have an escort of her choice so that her birthing experience is much improved. Children also are always covered for an escort. There's also coverage for a client to have more than one escort if needed for medical or legal reasons, and those are requests that are considered on a case-by-case basis. Maybe I could turn to Scott to speak about the process of applying for an escort and areas that you see that we could streamline.
Thanks very much. Escort travel is certainly something we know will continue to be a conversation that we need to have with probably through the AFN joint review when we're able to get back to the business of the medical transportation review. But at any point, we are certainly willing to work through our regional offices as well as through First Nations partners who administer aspects of non-insured to make sure that the policy framework is clear, well understood, and that is being applied in a consistent manner. And over time, and unfortunately I don't have good figures to provide you with the committee other than to say we do have high utilization of escort in NIHB. For example, we had nearly 1,600 mothers who traveled for childbirth, which is
I'm just going to interrupt you.
Okay.
I was looking for an answer on how you're going to make it better. You pointed to several areas. I appreciate that. I recently had a friend that had cancer, was very sick, and it was sent to Edmonton by air ambulance from Yellowknife, diagnosed with terminal cancer, and then was told to travel back on a commercial aircraft. He didn't have shoes. He didn't have a jacket because he was medevac there. I think we need to be a little more sensitive when it comes to dealing with people that are so sick that they are brought in with an air ambulance and they can't barely walk. It was really embarrassing to have to try to find a way to explain that or talk about that. And I think one of the key ways in improving the medical escorts element is to make the non-insured health benefit more culturally appropriate. In my riding, we have residents, we have elders in small communities who don't speak English. And a lot of them can't eat or refuse to eat hospital food or Western food. And they feel very uncomfortable just leaving the community to go to Yellowknife, for example, and never mind going south to larger centers like Edmonton. So I think, my question is what ways is the government able to make NIHB more culturally appropriate?
Well, I will just say, MP MacLeod, that I'm happy to take specifics of that particular case back to the department because I share your outrage. That shouldn't have happened to that individual, and we would like to look into the case. But I will say that, for example, you mentioned translation or personal care. There is coverage for an escort in those situations. A non-medical escort, such as a family member or a person chosen by the client, is covered to accompany them. So, listen, I think it's important when we hear cases like that, and really to all members of Parliament that hear a case like that in their constituency, that they bring it to me as the minister or to the department so that we can follow up and find out what went wrong. I obviously have no specifics about this case, but it shouldn't have happened. Someone shouldn't have been discharged with no shoes and no winter coat and stuck on a plane to travel back without any care. That's unacceptable, and we'll get to the bottom of that particular case.
Thank you, Mr. MacLeod. Mr. MacLeod, thank you. We'll go to Madame Gill. Madame Gill, vous avez 2 minutes et demie.
You have 2.5 minutes. Thank you. Still, concerning the administrative burden, Inuit and First Nations in Quebec are wondering because some communities are more hard hit when we talk about faxes and letters, and we talk about the administrative burden. In my riding, for example, there's a place where the mail arrives really sporadically, depending on the time of the year, and sometimes after 3, 4, 5, 6 weeks, with huge delays where there's no network, there might not be any internet access. So you can see the issue. Also for the question of language. Sometimes professionals don't want to deal with the administrative burden themselves. So I'm wondering what you could do. There's a language issue, and there's also the issue of arriving at the 21st century for some practices. So Indigenous peoples are not discouraged in making claims.
All very good points, Madame Gill. I will just say that the department makes every effort to be able to communicate in official languages, both official languages with providers. And I would imagine that there are things like direct deposit that are available for providers so that we can avoid delays with mail, for example. There are a number of other ways to make sure that people are getting their payments on time. If, with Mr. Chair, with your permission, I did want to just amend something I said earlier, so I'll leave that to you as when the best time is to make that amendment. But on your issue, Madame Gill, that is a commitment of the department that services are available both to client and practitioner in official languages, as well as a multiple of choices in terms of how payment is remitted.
Ce que je voulais dire en même temps, c'est
I also wanted to say I understand this, but in theory, that's one thing, but in practice, there are issues. I know some people who don't speak either of the languages, so it's very difficult for them. And I have to say, even literacy, sometimes this is a complex issue. They might not have an escort. So I think that we need to think about this and also think that it's very different depending on the territories, the communities, the demographic groups. So we want everyone to have access, but we have to make sure that everyone does have it and that we have to look at the different needs of people, because we see people in our offices that are not able to access services, and it's very difficult. Thank you, Mrs. Gill. You ended with a comment.
Minister Hajdu, if you would quickly make that amendment, and then we'll carry on.
Yes, I just wanted to say in response to MP McLeod's comment about the person discharged without shoes or shirt, I neglected to mention that the hospital in the territory would also have a high degree of responsibility in making sure that the person was cared for. And I will say that it's disappointing to see at all levels, provincial, municipal, governments, people abdicating their responsibility to provide equitable care. And that is a perfect example of a situation where a province or a provincial service needs to be reflecting on their treatment of the patients in their care.
Thank you. We'll go to Ms. Idlout now.
Thank you. My question is about medical escorts. We hear over and over that Nunavut Miud have to go on medical leave. And many of them, and most of them, require medical escorts to travel. They go on a volunteer basis as medical escorts, no pay. We want to make sure that those essential, much-needed service providers are paid or remunerated for their services, because some of those medical escorts can be gone a long time, up to a month, and they are away from their own families and children. They have to take leave from their jobs, and sometimes they lose their jobs when they become medical escorts, when they're escorting patients.
Thank you very much, MP Idlout. And I think this is a challenge with anyone who has a sick member of their family or a member of their family requiring medical care. Is the challenge of the support, the medical support person, the non-clinical medical support person's time away from their own daily activities. It's something I'm sure will come up in the review with the AFN, and we'll make sure that it's flagged. Right now, to my knowledge, medical escorts are not compensated. This isn't a unique problem in terms of Indigenous communities. We've certainly heard this in non-Indigenous communities as well, but there's a significant pressure when there is an aspect of travel and remoteness that's additional. So we'll flag that for a conversation with the AFN review and certainly follow up with you in the discussion that happens.
Very quickly, one question regarding is AFN also looking at Inuit issues? Or do you look after Inuit people in your region?
We will make sure, though, of course, through the new the new policy that's been approved by ITK, that ITK is fully consulted. On the compensation for medical escorts, I do know, though, and I'm not probably some MPs know more than I do, that there is a new benefit through employment insurance for caregiving of a very sick family member. And that was something that our Liberal government actually introduced and passed a number of years ago. So it's something to flag for escorts, that there is some provision of care through EI. Unfortunately, it wouldn't apply if the person was not employed, but there is a benefit for employed individuals losing access to income as a result of severe illness of a family.
Thank you, Ms. Edelhout. Colleagues, we only have a few minutes left. I'd like to finish the round two, but I would ask the Conservative and then the Liberal to limit their questions to a 2-minute period, please. And if that's possible, then I've got Mr. Vidal. Maybe it's Mr. Shields, but you've got 2 minutes.
Thank you, Mr. Chair. It's Mr. Shields. Quick question in the sense of establishing the fee-for-services for social determinants dental. Are those established by province? I know the fee scale for dentists in Alberta. Is it the same fee schedule for Indigenous services as it is for others? Do you adopt the dental fee-for-service scales?
Go ahead.
So we have a fee schedule that we've developed ourselves. It is based on every provincial dental association's fee guide, and we work within that fee guide in terms of reimbursing from restorative to preventative services, and we pay a range of around between 85 and 100% of the fee guide, but it's something that's set by the provincial dental associations.
85 to 100. Why don't you just adopt it directly?
It depends on the nature of the service that's being offered, and we try to reflect the fees that are also paid through private insurance as well as provincial programs as well.
I understand that, but there is a severe mistrust in the Indigenous population because of that variation. Do you understand that mistrust is there, of why they're treated differently?
It's certainly something that we hear about, and we've made a lot of investments over the last few years to make sure that our fees are competitive, and we work with every association to deal with those issues.
So you're aware, when we're talking about reconciliation, trust is critical. I don't know why they would trust us to begin with for what we've attempted to do to them. But when you have a differentiation, do you understand how hard that is to overcome when you continue to have a differentiated scale?
You know, maybe I can respond, Mr. Shields. I take it from the nature of your question that you will be supporting Budget 2022, and like the many other budgets that the Conservatives have voted against, that's how we actually get to a place where we can provide equity by continuing to make ambitious investments in the equal treatment of Indigenous people in this country. So I'll look forward to watching you vote.
Oh, thank you, Minister.
Thank you, Mr. Shields. Mr. Badaway, you have a couple of minutes.
Thank you, Mr. Chairman. Mr. Deutsch, I'm going to ask you a specific question, something I've been working on for the past few weeks with respect to access to advanced diabetes technologies for Indigenous adults who currently have only case-by-case access to advanced glucose monitoring technology through the NIHB program. Within that regard, and for example, an Indigenous adult who may be eligible to access the Ontario Drug Benefit Program could access advanced glucose monitoring technologies such as flash glucose monitoring. However, if they are not eligible for the public plan, nor have any access to a private insurance plan, they would have to be reviewed by the NIHB program before even being considered to have access to this life-changing diabetes technology. So the question, is this an issue of NIHB having the funding that they need to improve access to innovative technologies, which many non-Indigenous people already are benefiting from?
Maybe I can start.
Okay. Go ahead, Minister.
Parliamentary Secretary. Thanks for the hard question. But the honest answer is yes, we need additional funds to be able to universally cover that particular medical equipment, and I am working on that as we speak. It has undoubtedly been lobbied for by many pharmacists in my riding and across the country, and it is technology that can reduce the burden of illness for people living with diabetes and improve health outcomes. And I would argue decrease the burden on our healthcare systems as well, although that's never the primary reason why we would do something. So let me take that away and continue to work on that, and I'll look forward to your support in those efforts.
Great. Thank you, Minister.
Thank you, Mr. Badaway. And with that, I'd like to thank Minister Hajdu and her officials for coming today for this first hour of our afternoon committee. Very much appreciate your opening statements and answering our questions. And with that, colleagues, we're going to suspend momentarily as we prepare for the next panel. Thank you very much. Welcome everyone to the second hour of our committee today. Our panelists this time are Colleen Erickson, Board Chair of the First Nations Health Authority, with Richard Jock, CEO of the First Nations Health Authority. Secondly, we have Jesse Messier, Interim Manager, Health Services, First Nations of Quebec and Labrador Health and Social Services Commission, as well as Isabelle Verrette, Advisor, Health Access Services, First Nations of Quebec and Labrador Health and Social Services Commission. And the third group is Mr. Carl Dalton, CEO of the Anishinaabe-Aski Mental Health and Addictions Support Access Program, as well as Orpah McKenzie, Director, eHealth Telemedicine Services of the Anishinaabe Mental Health and Addiction Support Access Program. Welcome to our witnesses today. Some are in person, some are with us virtually. The way we proceed, as you probably know, is that each group will have 5 minutes to speak in the order in which I named them, and that will be followed by a question period. So if you're ready, either Ms. Erickson or Mr. Jock, you have the floor for 5 minutes.
Ms. Erickson, you're on mute.
Greetings. My name is Colleen Erickson, and I am Dekath from Nakazi, which is in the North Region. I'm also honored to serve as the chair of the board of the First Nations Health Authority. I would like to start by acknowledging the territory from which I call in from this morning, the land of the Squamish, the Musqueam, the Tsleil-Waututh, and I would like to thank the people who have endeared themselves to this land since time began for allowing us to conduct this business in their territory. I'd also like to acknowledge the chair and the members of the Senate Standing Committee. Thank you for the opportunity to be a witness in the study of the administration and accessibility of Indigenous people to the non-insured health benefits program. The First Nations Health Authority, the FNHA, is a health and wellness partner to over 150,000 First Nations people and 203 First Nations communities across BC. Alongside our governance partners, the First Nations Health Council and the First Nations Health Directors Association, we work together towards our shared vision of healthy, self-determining, and vibrant BC First Nations children, families, and communities. In 2013, the FNHA entered into a historic agreement with Health Canada to assume responsibility for delivering health benefits. During the following 5 years, the FNHA established new partnerships and engaged extensively with communities to redesign the benefits plan. The new wellness-centered plan focuses on removing barriers to accessing care while supporting our most vulnerable clients. The plan reflects the needs and the priorities of First Nations in BC and supports self-determination. Historic mistreatment of First Nations people in Canada has resulted in generations of trauma, racism, and unequal access to healthcare services. While Status First Nations people across Canada have access to basic health benefits, we believe that the policies and funding levels perpetuate health inequities. These challenges are further exacerbated by anti-Indigenous racism that exists in the health system. As part of our goal was to eliminate health disparities, and I will now invite our Chief Executive Officer, Richard Jock, to speak about the changes we have implemented to our benefits plan as a result of our extensive community consultations and to where we are going next in our transformation journey. Thank you. Richard?
Thank you, Colleen. And of course, part of our submission is we have submitted a brief to the committee, which gives a fair amount of detail about our delivery of the health services that we call First Nations health benefits, which are known nationally as non-insured health benefits. One of the things I just want to comment on in the short amount of time that we have left available is that partnership has been a key operative term and an approach that we've used throughout our work over the past 8 years. And for example, we partnered with communities as an important way to drive the work going forward. Similarly, we partnered with BC PharmaCare to create a new drug plan and a mechanism for delivering services very effectively. We used our experience there to engage further with communities on the development of an involved dental plan, which then has yielded a lot of benefits and success within the First Nations community and populations. We've also transformed our service delivery system from manual systems to electric systems, and have also included ways to not only access services in a more seamless way, to be clear and transparent about it, but also to provide quicker access and repayment where needed. We still have work to do in the areas of medical transportation, which I would say is our next challenge. But as I say, we will do that in partnership with a client-centered approach that measures satisfaction and provides continuous quality improvement as really a key principle. Thank you.
Thank you very much, Mr. Jock. We'll now turn to our second group of witnesses, Jessie Messier and Isabelle Verret. Not sure which one of you will speak or both, but you have 5 minutes.
Sorry. Second.
Bonjour. Hello. First of all, I would like to acknowledge the unceded territories that we are in. We thank the members of the Standing Committee for this invitation and for allowing us to present the key issues related to the First Nations administrations and access to the NIHB program. I'm Jessie Messier. I am an Indigenous person. I'm the acting manager of the health services at the First Nations of Quebec and Labrador Health and Social Services Commission. I'm accompanied by Isabelle Verret, who is Wendat and holds the position of Health Services Access Advisor. We'll begin by pointing out the complexity of the processes for accessing the program services. Indeed, these processes do not take into account the realities and needs of the First Nations. The administrative burden required to provide access to NIHB is exasperating, and a large majority of providers perceive it as a significant burden. Over the past few years, many providers have decided to stop working with the program, leaving patients to pay for services and to take the necessary steps to obtain reimbursement. It can take several weeks from the time a patient requests pre-authorization for a service to the time they receive an approval or denial from the program. This is very concerning, especially for remote and isolated communities where the number of professionals located near a community is limited. The lack of knowledge of the program service offer by professionals and First Nations is an additional obstacle to accessing service. The set of eligibility criteria for services and treatments is not shared, which represents a major obstacle for professionals who must determine the best treatment plan for their patients. This creates unacceptable delays for patients and professionals who must take specific steps to have some of these services covered by the program. This can have significant impact on the health of our populations. As a result, the program forces First Nations to justify certain medical treatments that are available to the vast majority of the Canadian population, which contributes to maintaining systemic racism against First Nations and the health system. In order to improve the knowledge of the program's professionals and access to services for patients, strategies have to be put forward. For example, information on the realities of First Nations and on the particularities of the services must be included in university training programs as well as in the training offered by the provincial health networks. Eligibility criteria must be shared openly with the professionals working with this clientele. Better accompaniment adapted to the local reality of Indigenous peoples would make it possible to increase access to services for a population with urgent health needs, considering, among other things, the prevalence of chronic diseases. An element that further complicates access to the program is the fact that the management of its various services is shared between the national office and the regional office. In recent years, the administration of some services were previously managed regionally, such as dental care, mental health counseling. This centralization has distorted the collaboration and communication that existed between regional administration, communities, clients, and service providers. An adapted approach, proximity, and the relationship of trust that were established facilitated better access to services and minimized the effects of several administrative irritants. Regional management also allowed for a better understanding of the specific needs of First Nations at a local level. Support and accompaniment to providers is now diluted in a uniform and rigid national approach to our reality in Quebec. We understand the objective of centralization was to better manage federal government resources. In reality, this has created significant challenges, delays in authorizations and reimbursement for services. It is crucial that quality control mechanisms be set up and closely monitored in collaboration with First Nations. As is the case for many programs and services dedicated to First Nations, the NIHB program is on the fringe of programs established by provincial governments, without any real link or complementarity of resources being put in place for the benefit of patients. Eligibility for certain provincial programs is often ambiguous and inconsistent. Flexibility in the accessibility of the NIHB program would allow for the implementation of services that are adapted and complementary. The issue of accountability for payment of services is an area which we wish to bring your attention. The NIHB is considered to be the final payer, which obliges First Nations to take steps with private or government insurance programs prior to any request. This creates significant and unreasonable delays and can represent complexity for people who are not familiar with this process or for whom English or French is not their first language. These elements are but concrete examples of the many issues that First Nations must deal with when accessing services under the NIHB program. It is essential that the process initiated in 2014 by the federal government as part of the joint review of the program continue in partnership with the First Nations in order to find concrete and sustainable solutions. In the meantime, the federal government must ensure that First Nations are kept at the heart. I'd ask you to conclude. To conclude, we believe that efforts must be made to support First Nations in the affirmation of their self-determination. Support and necessary resources must be made available to them to analyze and improve current service offer and eliminate any form of systemic discrimination that exists towards our populations. Thank you. A reminder. We do have simultaneous interpretation. I know there's a lot to say, but please don't go too fast. And this is for everyone. It allows for our interpreters to do their work. Thank you, Mrs. Messier.
Group, Mr. Carl Dalton and Orpah Mackenzie, who are in the room. You have 5 minutes, whichever one of you wishes to speak. Thank you.
Miigwech. Wajia kitinawa kakilong makaya biag koke konok ka kanat tamwadwe dwasa and mantuke nanakma huen kamino kyak huen kamino kisaka koke kamino menoyawan kamino kyak. Amen. I greet all the people that are joining us from a distance and for those that are here as well too. I'm asking the Lord to help us and bless us and I thank Him that He's given us a beautiful day today. I thank Him also for our health and well-being. Good afternoon. We are honored to have the opportunity to appear before you today to share the incredible effort of the NANHOPE Mental Health and Addiction Support Access Program in providing care to the 49 communities of the Anishinaabe Nation in Northern Ontario. My name is Orpah Mackenzie. I'm the Director of eHealth Services at Giwit-Nagugmakana eHealth Telemedicine, a provincially integrated telemedicine network that provides access to thousands of physicians, nurses, and allied healthcare providers for 26 communities. I am joined by Carl Dalton, CEO of Dalton Associates, a mental health organization that offers a culturally safe and attuned clinical workforce, as well as mental health program development and management expertise. In partnership, our organizations designed and deliver NANHOPE. NANHOPE began as an innovation in response to the NAN COVID-19 task team's investigations that revealed a high need for mental health and addiction support for the NAN region. Given the challenges that were caused or exacerbated by the pandemic and resultant restrictions, to this day, NANHOPE is the only NAN-wide mental health and addiction support program, and we are honored to have served over 1,000 NAN citizens since launching in August of 2020. NANHOPE strives to create a safe and trusting environment for the people and communities we serve. The fact that NANHOPE has been able to grow and expand is precisely because we have worked hard to build that trust and shared care within the NAN region. and have proven ourselves to be exceptionally responsive when needs arise that impact mental health and addictions at a community or individual level. I'll turn it over to Carl.
Thank you. To meet the needs of NAN citizens in both remote and urban settings, NAN Hope offers a virtual, holistic, rapid access approach to mental health, addiction, and crisis support that is available 24 hours a day, 7 days a week, 365 days a year by telephone, web chat, video, and text messages. NAN citizens have immediate access to crisis counseling, long-term counseling, navigation assistance, and ongoing case management, all of which has resulted in our ability to save lives in real time in partnership with our community partners. Our program is distinct from many existing services because we maintain relationships with clients, remote nursing stations, doctors, and community-based organizations. We accept referrals, we conduct outreach, we don't wait for calls to come in. We offer barrier-free services in English, Ojibwe, Ojibwe, and Cree. We have a strong roster of respected and experienced counselors, many of whom are Indigenous, and all of whom are regulated health professionals or trained in Indigenous cultural healing and helping practices. Uniquely, NAN Hope also hosts regular virtual healing circles and virtual community cultural gatherings, much of which have been well attended during the pandemic time. Currently, we are launching a mapping tool on the NAN Hope website after having extensively mapped existing local and regional mental health and addiction services. This will take the onus from NAN citizens who must often navigate confusing pathways and access to services in settings outside of their home. We can with this application, we can better fill gaps, ensure against duplication, and identify existing services. In addition to the virtual support offered by NAN Hope, we do receive calls from communities for in-person mental health services. Recently, we received some additional funding to answer this call. However, our request to extend that funding and to continue offering in-person services in remote communities that are in crisis has not yet been approved. We recommend that the Government of Canada invest in the growth of NAN Hope so we can deliver critical crisis and mental health services in remote or fly-in communities when called to do so. We wish to own space to deliver services in the urban centres of Thunder Bay, Central Ontario, and Timmins, Ontario, where many NAN citizens reside to receive in-person services and primary health care services. NAN Hope was originally only funded for 1 year. However, we have obtained an extension to March 31st, 2024. We are grateful for the additional 2 years of funding. However, we would like assurance that we're putting infrastructure in place over these years to deliver a longer-term mental health and addiction support access program in the North. We request a longer-term, increased funding to at least 5 years to allow NAN Hope to truly take root, grow, and gain sustainability. We appreciate your time and attention to these critical matters. This is an essential next step for continuity of mental health care in the NAN region. Thank you.
Thank you, Mr. Dalton. We'll now proceed to a round of questions, beginning with the Conservatives. I believe it's Mr. Shields for 6 minutes.
Thank you, Mr. Chair. Thank you for the witnesses being here today and sharing their information and stories with us. I would like to go to the witnesses here in the room who just finished. You said words like trust, sharing, relationships, referral, outreach. There obviously must have been some groundwork ahead of time in what you've done before you started this program. This just didn't start out of the blue. You've developed these things before, right?
Yes. Well, I think there were established partnerships from KO eHealth. KO has been in existence for about 30 years already. So we do have an established relationship with some of the communities. I would say about 26, at least the ones that we currently have telemedicine sites in. So it's been established. Telemedicine was established about 20 years ago.
Right. So you've done a lot of work in the past, which allowed you to take the next step. You ended talking about funding. And it's one of the things that I do talk about on this committee, in the sense you're program funded and you need more guarantee of that funding. You're talking about a program that's taken years of work to get to the stage that you were implementing the next stage, right? But funding is the key for this to continue.
We have built relationships for the last 25 years, and we work in remote communities and in different ways alongside community members. And so when the pandemic happened, there was a COVID-19 mental wellness task team that was that represented the communities across Nan region, and they made a request at that time to the federal government to receive a pandemic fund to essentially a 24/7 crisis service, and we enter that. So that service has gained and built trust over that year, and then has now, probably was needed for many years before this. And so as the uptake took on and the partnerships grew, it's now becoming, a consistent call for service from the communities themselves, both urban and the remote communities.
The need was there. You developed a program that sort of is beginning to work. You've got some outcomes that are working. You've got some positive outcomes. But the challenge is now of understanding how you're going to fund this ongoing. And that's what you're faced.
That's correct. We believe and we've heard clear feedback that this program should stick around for many years to come and continue to evolve and be responsive to the needs of the communities.
And you're establishing a sense of mental health and the addictions. That's a huge and growing problem.
Correct.
And you've identified it and you found a solution. Do you find other people coming to you and asking how you've done this?
Yes. When we initially we worked with the government and with the communities to get the funding approved, and we started the program in 30 days. Sir.
30 days.
30 days we had the counselors and the workforce available, and then we've built the infrastructure and evolved over time so that now not only are the communities reaching out for services, but well-trained, experienced Indigenous clinicians are reaching out to us and asking how they can be a part of it.
And you've mentioned that number of Indigenous people who understand culture, who understand the communities and understand the geography are involved in this. Are you attracting more then, as you say, more to this types of programs?
Yeah, I think that we're appealing to a workforce that is there, but want access they want to use their own choice and voice, as they know how community operations happen, they know how healing happens, and they want to say in that. And our program allows for that flexibility and for a responsive budget rather than a strict mandate.
So it's proactive in the sense these are going to lessen the costs in the future as well as saving lives, is what you're looking at.
That's correct.
Fantastic. Thank you, Mr. Chair.
Thank you, Mr. Shields. We'll go to Mr. Weiler. You have 6 minutes.
Thank you, Mr. Chair. I'd also like to thank the witnesses for joining today to provide their knowledge and experience to today's really important meeting and the study that we're doing. And I would like to begin by acknowledging that I'm streaming from Chaksay in the ancestral unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. We're quite fortunate earlier this week to have Dr. Evan Adams join our committee to share some of the thoughts of his lived experience in the early days of establishing the FNHA. But I'm very interested today to be able to hear from Ms. Erickson and Mr. Jock about the experience of FNHA in delivering healthcare with your approach focused on wellness. So maybe we could first start just with a general question, and perhaps you could describe the experience of FNHA in delivering the non-insured health benefits program in British Columbia.
Thank you. And I think that one of the key elements is really trying to focus on the patient, the client, the person. And I would say what we've done with the immediate set of transformations is to base our work on that and to also make the work accessible and transparent. So the PharmaCare program is one that we have designed in partnership with the provincial government, and which mirrors the types of therapeutics that are available to all people in BC. The other part of that is that that we also still own our program, and we are able to adjust that program to our specific needs and interests. So I would say that's one aspect. With dental and with pharmacy, in fact, what we've done is work with the providers. So one of the things that we've been able to do is to get almost a universal buy-in of the providers for this, and also have moved from a very slow and cumbersome paper process to electronic processing. So we do follow 100% of the fee guide, and it's and one that, as I said, is done in partnership and fully endorsed by the Dental Association of BC. So those kind of relationships are also important. And then simple or smaller things like eyeglasses and transforming those so that there's no longer waits or predeterminations really enable quicker access to things that are really needed. So I would say that's been our approach, and it has taken time, and it does also require us to have a continued partnership with the national program, because there are some areas that really continue to need resolution. And there are new things like devices were mentioned earlier, but also things like new drugs, biologicals that are new, very expensive, that really we need to look at ongoing and future solutions if we're going to have really a sustainable approach to this.
Right.
Oh, sorry, go ahead.
Oh, no, I was just going to say, I would just add that, one of the things about the FNHA is that we have really comprehensive engagement with our communities. And so as we roll these out, these plans are very much designed by the community. And as we roll them out, the community provides us with really very quick and comprehensive feedback as to what's working and what's not working. And so that really enables us to design a plan that serves, everybody.
Thank you both for that. And Ms. Erickson, maybe I could just quickly follow up on your last point there. Just kind of speaking to some of the advantages of being able to deliver healthcare in really, culturally appropriate and really contextually specific area. And so I'm just, maybe you could please speak a little bit more to how you're able to deliver services really at the local level in that manner.
Well, I think it, again, goes back to the engagement that's in the community. British Columbia is very diverse in that we have many nations, and so it's not one program that'll fit everybody. And so that, and I think that's what's so unique about our program here in British Columbia is that First Nations people in BC work very collectively and collaboratively to build the FNHA. And so it was many nations getting together. And so our engagement pathways, were established, and it was a very comprehensive process that took many years. I believe it was over 10 years before the First Nations assumed control of their health. And so having those comprehensive engagement pathways into the community, people very much are connected to their program and advise us as to how to design programs.
And if I could just add quickly, we have regional offices where we have VPs who are actually involved with local service delivery aspects. So that's not only the input and engagement, but right down to service delivery. So we are getting that closer to the ground.
Thank you. And maybe to touch on that as well, we've heard from other witnesses in this study that there's been issues with delays and administrative burdens. And I'm wondering how the FNHA has been able to approach issues like that, and if your model has been able to address that as well.
Well, I would say there are some key elements, and one of them is that the electronic system actually minimizes any delays. So the other part of that is by clearly following the fee schedule at 100%. The providers have confidence in what they can do, and that there's not a lot of checking back and forth. They can actually focus on providing service to the client. So when the providers are enabled, then they're able to provide that service, and the access results in much more engagement by the providers, so that we don't have the issues of people not wanting to provide services to First Nations people, or some of the complications and implications of having people pay up front. So I would say there are a number of areas that we do that on. And we also have apps for those that have phones and access to computers where people can check their eligibility, can actually see what they've been provided. So there's ways to do those kind of more forward-looking ways of approaching wellness overall. So I think we put a lot of premium on that and sort of the communication that goes with it.
Thank you, Mr. Weiler. On va aller à Madame Gill pour 6 minutes.
Mrs. Gill for 6 minutes. Thank you. I'd like to thank all the witnesses here today, and I would have questions specifically for Mrs. Messier and Mrs. Verre from the Quebec and Labrador Health Services Commission. So we don't have a lot of time. Mrs. Messier, could you give me more recommendations? You talked a lot about administration and management, but for sure you have priorities that you might recommend. What would you recommend the committee to do on an urgent basis to facilitate access to the Indigenous people? Yes, thank you. Thank you for your question. Many recommendations were made through the joint review of the program that started in 2014. I think that it's a priority that work continue in consultation with First Nations and also in cooperation and partnership with the First Nations. First Nations communities and different interest groups defending the interests of First Nations have developed mechanisms allowing them to identify creative means of offering services. Sometimes this is on the margins of processes and the administrative framework allowed for by the program. So I think that the federal government has to think of the different levels of services available for First Nations. Yeah, okay, I might slow down. I'll take into account. Yes, but don't hesitate to send us further notes. Thank you. This is a subject that raises a lot of interest and people are passionate about. I think we have to integrate a certain flexibility, allowing communities to suggest and implement innovative solutions. We're talking about transportation, dental care. There are ways to offer services, and sometimes to offer services privately. This can lead to overall savings for transportation. So we have to think about everything. This could be a way of managing public funds in the program and also to recognize the legitimacy of communities. They have to be at the very heart of the thought process and the solutions that might be proposed. I think that this is a central element. As of today, there should be no decision, no orientation, no change implemented within the NIHB program without having allowed the First Nations to analyze and the impact on their populations. We find this a shame. Oftentimes, the decisions are made unilaterally in the country without the First Nations being able to ensure safety nets for their population, think of different ways of doing things. So this is a key element in continuing our work here to try to improve the program, to make sure that work continues and that information is sent to professionals and support to the patients. There's data that we don't have. Patients that won't have obtained the required services. We have communications with professionals. We have a navigation specialist that offers support to the communities for the Quebec region. And the amount of professionals that have told us, if you knew how many patients, when we say that there's an extra cost, they're just going to let it go and not receive the service. And this data is not available. Earlier on, Valerie Gideon was saying that there were 15,000 dentists that were registered for the programs. How many of them are really respecting the services offered? Perhaps they're registered, but are they really accessible for the population? So there's a thing between people registered and people offering services, and I think that this has to be part of the thought process around improving the program. Do you have recommendations with regards to modulation? As you said, it depends on the community. Each community has different needs, different realities, but in an urban setting, in an isolated setting, of course, things are very different. And I have the impression that it's quite difficult because the realities are multiple and there's not one way of providing services. So I don't know if you have anything to add. You talked about isolated communities. Would you? Well, I'm thinking of the mail service, for example. All the administration of the program has to modernize, and this is very obvious. As for remote areas, one thing that we see is that very remote areas, we have to deal with very few professionals on the ground, and there's a type of monopoly. And then we have to deal with different programs, different parts of the programs of the NIHB that coexist. For example, medical transportation, transportation for medical reasons. This allows the residents or the population, the local population, to travel to obtain care. On the other hand, the program limits this type of transportation to the closest professional. It can be someone who's going to build exorbitant costs for services because they're in a region where there's a monopolistic situation. There's no competition. So this makes access even more hard for the population. So I think that to allow communities to identify their professionals, maybe to go even further, to identify the level of service that corresponds to their reality, this would be a way to facilitate access. Thank you. Mrs. Gill.
Mrs. Laut.
Thank you, Mr. Chairperson. First, I want to welcome you all. It's very useful information we're hearing because we also see when you present to us how capable we are as Aboriginal people in the field of work that we do. I think I will ask all of you in the order of your presentation. I want to ask you, with your experience in the health field and work to date, what recommendations do you have to improve NIHB as it exists today?
So I suggest we start, as Ms. Idlout has suggested, with the First Nations Health Authority.
I'll make a few comments, and then I'll ask Colleen to add to those. One of the things that has been really important is to adopt a different approach to designing the system. And I would say what we've learned through our process is that what has really worked well for us is when we pick a provider that will then partner with us to design the program. So rather than putting your specifications in your program design out and then having people bid on delivering that, what we've done is had much more a partnered approach to our work with providers. And this has yielded a much different product, one that's also based on mutual respect and respect for communities, as well as really a desire to provide that service in a culturally safe way. The other part of that is that we've worked with our partners to look at the administrative costs. So we started with a certain amount and we adjusted it based on our experience rather than really going hard and cold on the business side up front. What we've done is work with business to achieve our objectives. So we see doing that and using technology, and we look forward to doing the similar approach with medical transportation, which what I would say is one of the biggest challenges.
Merci. Est-ce que vous voulez commenter, Madame Messier?
Thank you. Mrs. Messier, do you have a comment?
Madame Messier, est-ce que...
Mrs. Messier, do you have a comment? Yes. Sorry, I didn't hear. So what I would like to add is that, yes, I mentioned during Mrs. Gill's question the issue of flexibility. I think that to have an overall improvement of the program, we need to have a thought process within which the interest of the client is at the heart of the process. So to make sure that each of the steps is adopted in order to facilitate the patient experience within this system, whether it be administrative steps, justifications, whether it be to facilitate the relationship that the patient might have with a professional. All of this is very confronting for a patient to have to ask their professional to justify something, especially when we look at the history of discrimination that Indigenous people have suffered in different health systems. So to make sure that each of these steps is undertaken with the best sincere interest of the well-being of patients. Thank you.
Would you care to reply to Ms. Sidlaut's question?
We get another summary of the question. We both missed it here. Our earpieces weren't operational. Please.
With your experience and work to date, what recommendations do you have to improve NIHB as it exists today? What improvements does it need?
Okay, I can probably speak to that. I worked as a health director for 10 years when I first went to KO, and I think that was one of the biggest issues that we experienced. There were a lot of issues around just the travel, being able to have to be heard, I guess, in the area of providing escorts, what we call the escorts, especially for the elderly and for the young children, and also for the people who were suffering mental health issues, those kind of things. That's what we were hearing. And I know that it's still ongoing. I really always think about we are on a line there where between the north, Sulakaut and Winnipeg, and many times when I fly, I see patients who are there. There's young moms as well too who are struggling with small children, and the elderly that are struggling to get in and out of planes and stuff, and nobody there to help them, or inadequate people to help them. And then the other thing is basically the whole vision care, non-insured. When you speak about about vision care, the lack of services in the communities. That's always been an ongoing thing. But I know that transportation, I know the Sulcode First Nations Health Authority. I'm a board member there too, and we get a lot of complaints from people who are experiencing difficulties in the area of non-insured when they're needing to travel out to medical care, especially care that's far from home. I mean, like going into, Thunder Bay, especially even for people who have not had the experience of going out and being placed in, especially the hotels. There are hostels there. Even the hostels may sometimes have their issues, but being placed in hotels that are very foreign to them, a very foreign environment, and not having somebody there to provide support for them, I think has been a major issue as well too.
Thank you. Thank you, Ms. McKenzie. Thank you, Ms. Sidlout. We'll start a second round. We'll get as far as we can within the time allotted. We'll start with Mr. Schmale. Mr. Schmale, you have 5 minutes.
Thank you very much, Sharon. Thank you, witnesses, for your testimony. Very interesting topic that we're talking about, and more interesting testimony that we're hearing today. Maybe I might start with the First Nations Health Authority. It might be a bit off topic, but it was kind of brought up in the opening testimony regarding mental health and addictions. I was very interested to see your two-eyed seeing program. Maybe you could just expand on that. I know it's a bit off topic, but I'd love to hear more about that and the results you're having.
Well, I would say two-eyed seeing is a concept that is very, very broad. Actually, it really refers to the ability to deal with the overall Canadian context, but also to see things from a First Nation context. So it does apply to our approach to mental health. It applies to our medical officers and how we provide our services to First Nations people, and it applies to the general notion that there's a First Nation perspective on health that's equally important as we approach health matters. That we look at things through that lens. So when we're delivering our programs and we do have an array of services which have been provided through virtual means because of pandemic. Part of what has been a critical element of that is making sure that our services are culturally grounded, but at minimum, the providers have gone through our prerequisites in terms of training so that we screen out those who are not interested or not capable of providing culturally safe services. So I would say that's a general context, and it applies to research, it applies to data, it really applies quite broadly across what and how we do our services. So Colleen, any additional comment?
I would just say that also that the First Nations people that we serve, are very much front and center, and remind us quite often that this is part of the critical part of all our programs. As we, especially in regard to mental health programs, that it has to be applicable to who we are at this moment, and two-eyed seeing is very critical part of that. And so, it also affects it creates real innovation I'm not sure what the word is, but it comes very much strikes home to who we are as First Nations people, and it goes further to the healing, and it's much faster.
In terms of interaction with Indigenous services, the department itself, how much interaction does your organization have?
I would say that that the partnerships we have includes our continued partnership with ISK. And I would say with the Ministry of Health in the province and also the Ministry of Mental Health and Addictions. So I would say that there is an ongoing relationship, and we have, for example, a letter of mutual understanding that we sign every year with the ADM of Indigenous Services Canada over the First Nations and Inuit Health Branch. But I would say folks like Valerie Gideon were really instrumental in helping us launch and implement our approach. So I would say that there's a continued relationship and a need to address some of the continued systemic barriers that we see, and also to deal with sustainability of our approach.
And we also have the tripartite agreement, whereby we meet with the government, the federal government and the provincial government twice a year to share, our what's happening in the FNHA and just reaffirm our partnerships.
Thank you, Mr. Schmale. We'll go to Mr. Pawlowski for 5 minutes.
Thank you, and I'd like to address my questions to the two people from NAN. Before I became a member of Parliament, 2.5 years ago, I was for 17 years an emergency room doctor in Thunder Bay. Back then, you didn't have your program of virtual mental health services. I'm happy to hear that you started that. But I wanted to ask you about the in-person services, which I gather you've applied for funding for that, but you, as of yet, have not gotten it. So let me tell you a kind of, I shouldn't tell you a story, because whatever I say doesn't get in as a witness. It's your testimony that does. But I know from working in Thunder Bay Emergency Room for a lot of years, there were a number of people that I got to know pretty well, because they were pretty consistently in emergency room, who were people who were homeless, had alcohol addiction problems, and were once from, and still were from, NAN communities. Sometimes when I see them repeatedly and they were getting increasingly high levels of alcohol, it was certainly pretty clear to me that if something wasn't done quickly, that they wouldn't be coming in anymore. And that certainly happened pretty frequently, that the homeless people, eventually you'd hear that somebody, like you say, you got to know them, died. And it was almost all related to alcohol. Now, I have to say, Thunder Bay Emerge didn't do a very good job on these people. Now, maybe they're doing a better job in the last couple of years. But as far as I know, we did very little. I mean, I don't know what addiction and mental health services were available. Detox certainly exists. The nursing stations in the communities exist. There are treatment programs, but I would occasionally phone up the nursing station from the communities these people came from and suggest you should think about flying them back up to your community and trying to straighten them out before it's too late. And often that was the case. But could you tell me a little bit about what existing programs are available for such people from your communities? Often they're down in Thunder Bay, in order to address their addiction and mental health problems.
Sure, thank you for your questions. In terms of what existing programs are available is just recently and throughout the pandemic, the communities have taken it upon themselves to build land-based treatment detox centers and wellness centers. So part of your advice, if you were calling up nurses stations a few years ago, that's exactly what's happening, building camps and working away at wellness piece by piece when they can. We're also hosting pretty innovative detox programs ourselves that are community-led or chief and council-led, where we're bringing in healthcare practitioners. I know some of innovative programs have been renting hotels for a couple of months to do a grand detox, do a lot of community development work in the meantime. So a lot of, by that I mean finding housing for people, making sure there's food, making sure there's opportunities for family to join them or care. So we're trying to make sure that there's an aftercare plan once we go through this piece. The reality is that many people are still go through the public detox system, which means we do our best and are building the technology to know wait times for beds when something opens up, so that doctors can start to call in and ask for that. So those, that's something an emergency doctor often calls us. As soon as we started the program, we heard from doctors right away in the hospitals, and we started to pick up some of the aftercare, so that when they were released, there at least was a contact. And then in the last 2 months, we've had a proof of concept with delivering in-person services under the NANHOPE piece, so where we have a lot of virtual care navigation, but we actually have people in the urban centers now that can go pick people up outside after emergency, get them to a hostel or housing component, make sure they have food. And we've had, great feedback in the last 2 months. And so that's what that, we had applied for a year of funding. We received 2 months.
Okay. So who did you apply for the funding with?
The
government program?
The federal government had a public health measures surge capacity funding available to us, which we were made aware of, and we worked together with our partners to apply for.
I certainly welcome to follow up with my office, and I can kind of follow up with that and try to encourage the government to do that. But the other thing,
Mr. Pawlowski, we're at our limit, unfortunately. Ms. Gill, vous avez 2 minutes et demie.
Merci, Monsieur.
2.5 minutes. Thank you. I'd like to ask another question to Mrs. Messier with regards to this idea that you mentioned earlier to improve communications, collaboration, and consultation between all the stakeholders. And she spoke about the federal government, but also the Quebec government and First Nations. So I would like for her to add some detail to this. Thank you. It's essential, and it's obvious also that mechanisms should be implemented to facilitate the creation of a continuum of care. The way things happen now on a daily basis, people arrive. There's a main healthcare network in place. They offer frontline services, first level, second level, third level, and then this will be funded by the provincial government, but there's no real tie-in when patients are discharged. There's nothing to facilitate the continuum of care. So there's not really a link with the community. Stakeholders that discharge the patients don't really know what the offer of service from the federal government. Sometimes they leave. They don't have the correct authorization or equipment, and we have to make sure that each of the stakeholders, whether it be the federal government, the provincial government, but there's also a role that needs to be played by the communities. This is central. We need to optimize collaboration of each of them to be able to implement a continuum of care for the patient, so that the patient doesn't have to try to navigate within a system and to try to deal or to jump over hurdles. So this system has to put an end to all these jurisdictional barriers. I have another question, Mrs. Messier. It has to do with funding of healthcare. We know that healthcare, whether it be in Quebec, well, in all the provinces it's the same. There are do you think that healthcare transfer increases would have an impact, a positive impact for First Nations? And also all the other improvements that we need. But do you think that increasing healthcare transfers would have a positive impact for First Nations? It could, if it comes with an obligation that the provincial government has to provide services to the First Nations. Right now in Quebec, our current reality is that services offered, well, the provincial government offers no service within Indigenous communities other than medical services. I'm excluding the Cree Nation. This is a First Nation, but has a specific agreement with the province. But for other communities, if we're talking about healthcare professionals, specialists, these services are not being provided within First Nations communities. So if this doesn't come with a commitment to provide concrete services to the First Nations communities, regardless of their place of residence, the impact might not be as great. Thank you, Mrs. Gill. We'll conclude with Mrs. Eatlout.
Half minutes.
Thank you so much. I just have a quick question to follow up on MP Palevsky's questions and experience as a doctor, and what I'm sure is much of the experience of the healthcare system that provides services to First Nations, Métis, and Inuit. Would each witness agree with me that what they experience as service providers when they see First Nations, Métis, Inuit patients is the direct result of the deep impacts of colonialism, and because of that direct impact of colonialism, now is more important than ever that the federal government has the responsibility to provide holistic, culturally appropriate, and sustainable funding to address these mental health issues so that we can ensure that the impacts of colonialism are being reduced.
Thank you. A big question, but please give short answers. We'll start with the FNHA.
I would just say there's two aspects to colonialism, and one of them is really need to focus on the residential school context. And to realize that we need to look at trauma-based services, that we need to refocus much of what we do to look at nation-based approaches to have these models of trauma-based services and healing. And I think this is totally consistent with Truth and Reconciliation Commission, but I would say is also based on what we're experiencing here in BC with Te Kamloops, their discovery of 215 graves. But also this is really widespread and affecting every community in BC, and I would assume across Canada. Colleen?
I would just concur with your comments, Richard, and just say that the FNHA has, since the discovery of the graves, the FNHA has had to be very diligent in our partnerships with the ministries and with all agencies to deal with the crisis that was before us. And so I think that going back to the two-eyed seeing and the fact that we see things and we deliver innovative programs and that are designed to address, colonial structures and the institutionalized programs that we received. They've been innovated. So I think that, our response has been a little bit more comprehensive.
Thank you, Ms. Erickson. Madame Messier, est-ce que vous voulez commenter?
Mrs. Messier, do you want to comment? Yes, briefly. We are not an organization that offers direct services to the population. However, the dramatic story of Joyce Echaquan in Quebec has highlighted in a very critical way the impact of colonialism and discrimination. And I can only adhere to the position that is to reflect and to encourage a holistic approach. It has to be determined by the Indigenous peoples and the First Nations themselves. Thank you.
Mr. Dalton or Ms. McKenzie, would you like to respond to Ms. Eatlout's question?
I could respond, I guess. Yes, I really see it in my work over the many years that colonialism definitely has and had an impact on the lives of Anishinaabe people. I can only speak for own people because that's where I've worked most of my life, and I think that that working together, I think in the last few years with various levels of government and other groups and that together to create programs together has been one of the main things that we've done to try and to ensure that everybody knows where we're coming from, that we have a voice at whatever it is, that project that we're working on, especially in the area of virtual emergency care, which was started about 4 years ago, and we now have 17 communities hooked up to emergency virtual care. And this year we've been working on 4 extra sites. But with the pandemic, it's been slow going there. So we're still working on it. But I think that the more that we try and work together, and I look at some of the things from the work that's been done with the I forget what it's called, but anyway, that if we can take a look at some of those recommendations, I think that would help us to address some of the issues that have been, I guess, plaguing us in the area of health and mental health over so many years.
Thank you very much, Ms. McKenzie. This brings our panel to a close. I would like to thank all of the witnesses for being with us this afternoon. Merci pour vos témoignages.
Thank you for your testimony. Thank you for having answered our questions. It's been extremely informative for the committee. This will help us in our deliberations.
Wishing everyone a happy Mother's Day. And with that, this meeting is adjourned. Thank you.